My question is if there is any research going on around like stem cells and if there is any promising views of that with Syringomyelia or Chiari, and also just like the genomics of it, if there is just research going on around that. I'm just curious about that.
I can speak a little bit about the, I don't know of any stem cell studies happening in Chiari. There are some studies coming out about the genomics and the specific genetics of Chiari. There's a study that was published, I think, last year that showed in a group of children from Salt Lake City that there's familial clustering of groups of genes that may predispose to Chiari malformations. But it's all very preliminary right now. So I would say in the next 5 years, there should be some good genomic information coming out from the WashU group and the big consortium that they're part of.
Okay, thank you.
They've also had some recent studies look at mesenchymal stem cells and actually placing cells within the cystic cavity of a syrinx and seeing some reduction in pain. They don't really talk about neurologic deficits or such. My expectation is that stem cells, or at least mesenchymal stem cells, likely won't have an impact on the neurologic compromise. We administered mesenchymal stem cells to, I think it was about 42 patients with stroke, long-term survivors, and saw a decrease in depression and basically an increase in their ability to be autonomous. But we really saw no standout changes in weakness, sensory loss, pain, or things of that sort.
Could I just ask what those specific type of stem cells are? Mesenchymal is what you said?
Yeah, the mesenchymal stem cells are usually derived from bone marrow.
Okay.
Usually donor bone marrow, potentially your own bone marrow. And those tend to be the cells that are studied more commonly, at least currently. There's different variants of cells. Every laboratory, every university has their own variant of mesenchymal stem cells. And the approach of the FDA is to consider each one of these groups of stem cells as a different drug.
Yeah.
The other types would be neuronal stem cells or fetal neuronal stem cells. But I haven't had any experience with fetal neuronal cells.
Did it affect the syrinx at all, or just the symptoms of pain?
The reports, and actually in my talk, I'll show you the abstracts specifically just as a kind of an update on what I think is innovative approaches. But I don't know that they were so interested in the size of the syrinx as much it was in resolution of pain.
Thank you.
Hello, hello. Thank you very much. The reactive atlantoaxial membrane. I just want to say a couple of things about that. First of all, is that there was some, not only is the posterior fossa small for quite a few people, but there's also evidence that the bone internal internal diameter of the cervical vertebrae are enlarged when you've got a high cervical syrinx. So if you've got something idiopathic, in other words, that's quite likely to be related to small posterior fossa, not only have you got the bony abnormality of the skull, you've got the internal cervical bones, the inside bit seems to have expanded. Now, I don't know whether the outside was measured at the same time. I don't think it was. In fact, I'm pretty sure it wasn't. But that would all fit with there being some kind of distending force for those patients that you've chosen. So first of all, nice, and second of all, that would fit with some old evidence. The other thing I just wanted to comment was that it's a shame to see the conclusions about changes in that membrane as being in conflict. So there is a possibility that small posterior fossa could make you born with a big head. So it's possible that there's both a big head and a small head consequences. So we could talk about that afterwards. I'm not going to grind on about it now. But it's really important that we don't necessarily see people's thoughts and conclusions about evidence that seems, similar pieces of evidence as necessarily representing conflict. So, for example, low-set ears, Gardner got it into his head that low-set ears were an important sign for syrinx patients, whereas, they were looking at wasted hands and pain and sensory, dissociation and all that. And then Gardner just spotted these low ears, and it's possible to marry together these observations if you think about what's happening over the course of time. So, for example, you're not going to find an association between Chiari and birth injury in places where there's very high cesarean rates. So we just, I just appeal for a little bit of, just a bit of care there rather than throwing out somebody else's conclusion, because I think that's led to a lot of mistakes. But anyway, it was a very nice morning, and I love this. I love the presentation on that membrane. Thank you very much. Catch you later, hopefully.
Yeah, thanks for your comment. And certainly our findings are suggestive that they're in contradiction with the previous findings, and in no way would we discount what they've reported. And they had a very cogent hypothesis that they came up with. And I think it just kind of answers the question that it may be different for different scenarios also. To your comment about the dilation of the cervical canal, the way I think about that is I liken it to patients with neurofibromatosis who have dural ectasia, and it expands the neural foramen and causes progressive scoliosis because of the thinning of the dura in those patients. And in patients with syrinx, it can be, as some of our basic science colleagues have demonstrated recently, it can be hyperdynamic locally. And it may cause a similar type of effect there.
Yeah, that evidence, there's so much evidence for that. I'm kind of doing my nut here. It's this pressure instability that I'm talking about. So distension and filling is this hyperdynamic, pressure instability. This evidence is 60 years old. We've got to stop banging on about it and accept it. It's real. It's important. But this hyperdynamic stuff they see with CSF and arteries is an epiphenomenon potentially for instability that's related to physical movement of the body. So all this Valsalva stuff and sneezing and change in level that you're telling us about, this CSF movement on a cine and the pulsation of the cerebellar tonsils, it's all put, it's a great big sign saying, look, look, look. But you can't measure dynamic, pressure instability on a patient who's lying down, relaxed. You have to, we can't. Or we have to look sideways at the stuff that, it's screaming at us. Valsalva, pushing. What did Paolo say about childbirth and push, pull, push, pull? I'm sorry. I'll catch you later.
Hi, I've got a question on EDS and somebody who has been athletic most of their life. And it's my daughter. She has been diagnosed with EDS, but her question is there a top end of intensity of exercise that she should not do? Now she's powerlifting. She used to be a soccer player. But when I see pictures of when she powerlifted in one, here's these veins. And so that's my question. Should people with EDS limit themselves in some way? Or not?
It's a good question. At our peer review meetings, that question will come up and people will fight all day about it. So there are varied opinions based upon that. I know in the realm of pediatrics, I tend to be more aggressive with allowing kids to participate in sports at the NCAA level 1 football programs. If somebody basically just has a routine imaging study that shows the presence of a Chiari malformation, we'll usually let them continue in the absence of cervical spinal stenosis or in the absence of a presentation that would suggest that it is problematic. But then some people don't feel comfortable with that and would advise people against aggressive activity. So I think it's a very good question. It's interesting because you're going to get a lot of very good answers.
Hello. I'm sorry to sidetrack a little the Q&A. I wanted to ask you, especially to Dr. Heiss, but to everyone, speaking literature-wise, psychiatric comorbidities, aside maybe from reactive depression, are relatively unaddressed in Chiari malformation especially, and only mentioned in spare case reports. You spoke about measuring with the Karnofsky scale, the overall performance, but were mental health issues and mental health measures taken into consideration? And secondarily, also sexual dysfunctions, because like literally wise, 70% of men with Chiari malformation lament some form of sexual dysfunction. And so where was that taken into consideration in your study, or is it going to be taken into future considerations? Thank you.
Right. Well, you have to determine the primary outcome, and that's to decide whether statistically one group is different from another. And then the next level are secondary and tertiary outcome. And then there's everyone has a history in physical where, those things are mentioned. So that what you're mentioning is something in a study that you could find with data mining. So I think that, yes, that would be put in a paper, in a summary for a study. But if you do a natural history study, what you're doing is you're trying to come up with questions which are posed as hypotheses, and you're mentioning some very good points. And the psychologist yesterday, neuropsychologist, she talked about how depression can make Chiari symptoms worse, and Chiari symptoms can make depression worse. So I think there's some understanding of that. But you asked about 4 or 5 great questions that could form the basis of a hypothesis-driven study that maybe ASAP would be interested in funding. So you're on the right track. But I think that that's why the support groups, what you mentioned, that there definitely are those problems, in somebody. Yeah.
Good morning. So what would be, to follow up on his question, what would be the proper channel to try to sign up for one of those studies, or get in the correct position to approach one of you for getting into a study?
All right. Well, that natural history study, we've finished enrollment. We're going to finish the 5-year follow-up, next July, I think. So we don't have another one like that scheduled, but other people are having registries and so forth where they're capturing symptoms and so forth. So I think that's on the horizon. I think my understanding is that some groups like Dr. Labuta's group and ASAP are going to collaborate. So I think that feeling of cooperativeness between groups would foster studies that could enroll more people, and you could really explore some things like that. But anyways, I'm planning other studies. It's difficult to get studies approved. To tell you the truth, I mean, it's not like you could think of something and they get approved. You have to go through scientific review and you have to go through an IRB, and so it's not trivial. And I'd like to live forever, but I'm not going to, so I have to realize that too. So anyways, there are lots of younger people who can do what you're talking about.
Hello, I think this question would be for Dr. Heiss. Your research was awesome. Could you speak to any observations you have about the non-surgical Syringomyelia patients and how that affects their quality of life? It looked like from the research you could determine that the patients that were operated on, there was a significant improvement in quality of life.
Right. Well, we are evidence-based, and like Dr. Batzdorf wrote a very good article on syrinxes with sharp ends that generally aren't quite as large as other syrinxes that are rounded on their ends and distend the spinal cord. So the ones that don't really make the spinal cord larger, they don't need to be operated on. The syrinxes that distend the spinal cord, then they have a mechanism of actually injuring the spinal cord. In other words, pressure inside the spinal cord would cause injury to the nerves inside the spinal cord. The nerves to your legs, nerves to your arms, nerves for sensation, nerves for pain. So anyways, the people who didn't have surgery usually had the smaller syrinxes. Now, that being said, you can have a small syrinx and you can have another condition called tethering that can cause your neurologic deficit just because it makes the spinal cord, gives it less blood flow in one area, and the syrinx is just an indication that the spinal cord's sick, but it's not really the syrinx itself that's causing the spinal cord damage. So you just need to see somebody who can understand those things. But if it's one of these thin syrinxes that Dr. Batzdorf described as an enlarged central canal, those don't need to be operated on. And there's other evidence. If you do a cine MRI, the fluid doesn't flow in those syrinxes. That's been a finding. I don't know if our neuroradiologists will confirm that, but so it's different. So a syrinx is not just a pool of fluid in the spinal cord. It's acted on the spinal cord. It's softened the spinal cord. It's like, I don't know if you've had a wealthy upbringing, but like my mom would smack the meat before she would cook it. The spinal cord has to be softened up to expand because otherwise the membranes around the spinal cord are pretty tough. So it's a long process. It takes a long time for the syrinx to get bigger. A long time for it to go away, sometimes, maybe a year or two sometimes.
So that's a question that I have with regard to then for patients who do have syringomyelia, with regard to then in terms of just living every day and management and reducing impacts or having further damage. There's a member in our support group who's an oncologist who asked me to ask this question, and it ties in. It was her observation that in searching Google, there was large literature on physical therapy recommendations for dogs who are especially susceptible to syrinx and syringomyelia. So she's talking about the Cavalier Spaniel stuff. And she says there's strikingly little guidance published on best safe physical therapy and safe exercise to benefit humans with these conditions. Can any of the presenters comment on this or point out resources to guide us in how to seek safe and effective physical therapy or physiatry and rehab to maintain our strength and minimize symptoms for adults with syringomyelia. And so there's just a big absence of, but what can we do? Because what we don't want to do is impact that in a way that then creates further damage.
Cormac's title of that, his talk this afternoon should help, the sport thing. So there's a good guy called Jamie MacDonald who's the cheerleader for Anne Connery Trust, and he got better from his syrinx by playing swing ball with his mum. So he did Jamie MacDonald, I can't remember the title of his book. So after he got better from childhood cancer and syringomyelia, he runs across America where he puts his stuff on a trolley and runs. And that's now he's better. So the message that Jamie would tell you is probably do what you can and do aerobic. And what the guy with the stonemason would tell you with his terrible syrinx, who was a stonemason for 20 years, is he ignored the pain. He ignored everything until he had horrendous syringomyelia. So don't be a stonemason. Play swing ball. In other words, avoid too much Valsalva. Have a cesarean if you think you're going to need to push for 56 hours. And have a nice day.
Okay, that's going to be it for questions now. We're heading